Yes, I have a question for Dr. Roberts. As you were talking about the kind of procedure of assisted suicide and this cocktail of drugs, and it made me think to the whole controversy over capital punishment. And my understanding, not knowing a lot, is that the drug companies are kind of against that, and they won't even provide the drugs to do capital punishment. And so they have to do all these other things and all that. So I'm curious if you have any insight into what the drug industry, how they feel about this, and then how that would be contrasted from their stance kind of on capital punishment.
This is Washington, so I get to say, Senator, I cannot comment on this at this time. I would love to comment, but it's out of my realm of expertise and knowledge base. But, Counselor? I don't know. Okay.
Good question. I don't know.
We don't know the answer to that one. Any other questions?
Bill, I have a general broad understanding for pro-abortion supporters, what their kind of motivation politically and culturally and kind of who they are and why abortion kind of fits into their agenda and promotes their stuff. But I'm having trouble wrapping my brain around how euthanasia and assisted suicide fits into someone's cultural agenda and what do they get out of it? Who are these folks and why are they pushing this?
Yeah, I think that's a really good question. I think it's more difficult for me too, except, I understand, some people, I suppose, legitimately but misguidedly think this is compassionate, or, maybe they believe they have an extreme view, an individual right to do whatever you want, and are against restraints or constraints of a patriarchal society, or, cultural Marxism kind of thing. But beyond that, I'm not sure. I don't know, but it's very powerful. So I think it touches legitimate pain we all have when we see people we love suffer, and we want to do something for that. So they feed off that, but I'm not sure beyond that.
There's just a lot of, the suffering. I think that everybody and all of us, even in the medical community, we want things to be over because we see what everybody's going through. And I think that's driving it. And then in the middle of it all is this sense of autonomy. Autonomy drives so much. Autonomy, though, is one of several dimensions of legitimate medical ethics: benevolence, non-maleficence, justice, community, accountability being the others. But when autonomy seems to take over, it takes on this, this is what I am entitled to. And it occurs in the setting of immense pain and suffering, and we want it to be over. We see it differently. There's a way to allow it to be over, but legitimately through palliative care, hospice, and very careful critical care. But it has momentum for those reasons, I think.
I would also, I would like to add that I think that healthcare rationing concerns, the costs for insurance companies, there's an incentive for them to support, and there's a number of articles and information that basically document the support of the insurance companies in the organizations, in some of the organizations that are promoting this. So all of those are factors, I think, as well. And the spiritual issue, people are afraid of death. So if I can schedule it and put it in my iPad, it's really not death that is controlling me. I got control of it. So there's another question over there. There's another, John, there's another one back there too. Okay.
I'm still formulating this question, so forgive me if it's not completely clear. Picking up on the fear of death, I think part of what I've seen, I spent a year as a hospital chaplain, and I saw a lot of doctors who want to help people, and they know how to help people by doing stuff for them, when sometimes it's not really the best thing to continue to pursue intense care, right? And so I wonder too, from both perhaps a medical perspective and then also from our church perspectives, if you have any ideas on how we help people think about care several steps back from that point, so that I think sometimes the prolonged suffering comes because we've pursued active care to such a point where maybe we should have stopped before that. Can you speak to that at all?
Do I hear an amen? Okay, all right. God be praised. Okay. So I can speak from my own experience in the intensive care unit. Many times when patients get to us, it is because the right conversations and the right goals of care and realistic goals of care have not been set 6 months prior. And we can get pretty frustrated as ICU docs, regardless of our religious orientation, when we've got someone and we can tell how this is going to go. I know exactly how this is going to play out. And yet they've never heard to date from their oncologist, from their pulmonary doctor or cardiologist, that the ball games, we're in the seventh inning here, and it's almost over. They haven't heard that. And I'm not sure where in fellowship training they teach doctors in these various specialties how to do this. It's supposed to be a requirement, but they land on our doorstep. We've instituted at our hospital a program where there are certain clinical triggers that are met, so that at least in the intensive care unit, before we put them on the ventilator, on continuous dialysis, on medicine to support their blood pressure with no clear endpoint, a Sarah Palin bridge to nowhere, if you will, pardon the thing, and that's what it is. And I use that term talking to families. That everything we do in the ICU is a bridge to either recovery or to definitive treatment. And if it becomes a bridge to nowhere, we have to reassess. So we have clinical triggers within 24 hours of admission. What's the nature of the diagnosis? What are the indicators of various system malfunction? And if certain criteria are met, that mandates a sit down, probably more formally than we do normally, with nursing, pastoral care, the attending physician of record, and palliative care to get them on board right up front. And what we found is that that things go a little more smoothly as we decide, well, we're not going to do dialysis. Or maybe we're going to try dialysis for a set period of days because there's no data to support continuing it. There's nothing easy about these, because then the question is, if the decision is finally, or the discussion comes back to stopping treatment that's been started, then what is the proximate cause of the patient's death? Is it the fact that I am stopping the ventilator with them heavily sedated, or is it the underlying disease that gets them there? In medical ethics and Christian ethics in this country, not so in all religions, but most religions, withholding treatment is the equivalent of withdrawing treatment. Withdrawing treatment is the equivalent of withholding treatment, ethically the same, and it's held in our mindset, in our culture, and I think reasonably so, that when we withdraw care, it is not us that's killing the patient, it's the disease that got him there. But yeah, long-winded answer. The earlier the conversations get had, the better. That which I can do is in the ICU, and we're trying to do this better.
Yeah,
I think we have-
I'm a retired physician,
Oh,
and
okay.
number one, I would hate to have to kill my patients. I mean, I wouldn't be here. But,
I've had patients that want to kill me. Probably.
Right, well, yeah, and the same patient. But I've had many patients, I was a psychiatrist, many patients who begged me to kill them, and I think, and there's a whole group of people who are hopelessly ill. There's nothing more I could do for them. They were incredibly depressed. And I think the answer would, they needed spiritual care. But, their argument is, you can't do anything for me, I want to die. And I think we need to address that in any discussion about physician-assisted suicide. I'm totally against killing them. And all I could say to them was, I'm not going to desert you. Maybe I can't help you, but I can see you, I can hold your hand, I can be with you. But you know, there's just a lot of very chronically ill patients who are not going to die soon.
I would add Edmund Pellegrino, who was this world-renowned ethicist at Georgetown for many years, always taught that, you know, as much as you vehemently disagree with the people who are pushing the other side, you got to do it respectfully and nicely and in a scholarly way. Well, listening to this hearing, and if you have 15 hours of spare time and a lot of coffee, you can go back and listen to the whole DC City Council hearing. Some of the arguments and some of the personalities that came out on the pro-assisted suicide side were Looney Tunes. It was just really ridiculous. But we are commanded to love these people, and I pray for Che.
All right, Faith? Oh, okay. There you go. I'm sorry, sir.
This is slightly different, but in the same area. Could you speak to do not revive orders
Do not recess.
or requests?
Sure. How long do I have? Okay.
Amen.
So do not resuscitate orders. I think, you know, everything sort of depends on when condition you check into the hospital with. I would like to be fully resuscitated because I'm not particularly sick. But on the other hand, we are trying to rethink and reword our DNR orders along the lines of allow natural death orders, or the AND, allow natural death. These are, from a Christian medical ethical standpoint, these are absolutely appropriate. You can be, to have a DNR order in place does not, in our mind, and when the appropriate diagnosis is applied appropriately, does not constitute physician-assisted suicide. Would you agree with that, Counselor? Yeah. Does that answer the question?
We have one more question over here from Faith.
Okay, this is for Bill. I'm intrigued by this idea of compassion and how it fits into, you know, the kinds of false narratives that are going on in many issues today. There's Walker Percy writes that compassion leads to the gas chamber. I wonder if you could discuss a little bit about if you think that this issue, like, you know, about Sudan, the whole idea of moral equivalency and how that fits into this idea in assisted suicide and euthanasia.
Well, Faith, I'm let me know if if I don't follow this where you wanted to go. But I mean, I think that, you know, when I made my talk and I said they're not Nazi doctors, because, and the reason is because they're doctors who have been under the sway of bad ideas in the Netherlands. Because if we separate people into the Nazis, who are the irredeemably evil, and us, who are all good, then guess what? We learn no lessons from history. We learn nothing. History might as well not happen, because the lesson of history is, and of course the lesson of the Christian church is, every single one of us could end up doing the thing we most revile and know is wrong. And we have to have a lot of supports, including the church and other Christians and communities and everything else, to do the right thing. It's, you know, so the compassion that leads to the concentration camp, you know, historically that was true. They started euthanizing the kids who were handicapped. And the German medical establishment, you know, the Nazis came after the German medical establishment had decided certain lives were not worth living. And if you make that, if you buy that premise, I agree with Percy, it's inevitable, the concentration camp, because, and you can even see it as an, you know, the Nazis called it a healing work, or they, you know, it was, I mean, so I think that, you know, I saw a movie, Faith, the other day. I forgot the name of it, but had to do with these Muslim tribesmen in Sudan taking the black people from the South as slaves, and that's something that, you know, there was real slavery, and it was done. And how did those people who took the slaves justify it to themselves? Those other people were not people. They were abid, I believe, which means firewood or what. They're not human beings. That's what you define somebody. You know, this is the issue, is you define some human beings outside of what I call the circle of protection, and you can't stop it. It's only the powerful. I live in Northwest D.C. Nobody in Northwest D.C. is ever going to pass a law that hurts their self-interest. Not, not evil, but they're powerful. It's going to be the people on the margins. And, so we want to have laws that protect the quality of each human being. You don't have to do anything else to earn that other than just be a human being.